Hey, Sarah, we have everybody here just on our end, just an FYI.
Okay, great. We'll go ahead and I'll come on at 9 o'clock and just let people know that we'll get started in a couple minutes.
Sounds good.
I just started putting it out.
Hi everyone, thanks for joining us this morning. We'll go ahead and give people 1 to 2 more minutes to log in before we get started. Great. Hi, everyone. Thanks for joining us this morning for the follow-up and Q&A session. Hopefully everybody was able to join for the first webinar we hosted on the Healthy Neighborhoods and Healthy Families Initiative, but if you weren't, we do have the recording available on the Institute website, and we can also circulate it as a follow-up to today's webinar. So today we have Nick Jones on the line from Nationwide Children's Hospital and a couple of his colleagues in the room to help us answer some of the questions that people asked as a follow-up to last week's session. And just a couple housekeeping items. Everyone is muted right now, but you can use the chat and the Q&A function to submit any questions you have throughout the Q&A session. Nick, if you want to go ahead and introduce some of the others in the room with you before we go ahead and jump into the Q&A, please go ahead and do that.
Great, thanks, Sarah. Hello, everyone. Nick Jones with Nationwide Children's Hospital and our Healthy Neighborhoods, Healthy Families initiative, which is a five-pronged, place-based effort around the south side of Columbus in Ohio here, focused on affordable housing, education, safety, wellness, and employment. And I have three of my colleagues in here who introduced themselves, starting with Dr. Kelly Kelleher.
Hi, this is Kelly Kelleher. I'm a pediatrician here at Nationwide Children's Hospital and work in community health services as well. And right now I'll be talking with you a little bit this morning about some of our housing initiatives with Gretchen.
Good morning, this is Gretchen West. I am the Executive Director of Healthy Homes, which is the affordable housing prong of HNHF. I'm charged with overseeing our three programs, which are home ownership, home repair, and rental.
And good morning, everyone. My name is Sheldon Johnson. I have the pleasure of serving as the Managing Director of Community Development for All People. CD4AP is a faith-based community development corporation with a mission to improve the quality of life for all residents here on the South Side. We partner very closely with Nationwide Children's Hospital, particularly through the Healthy Homes Initiative and through a variety of the other work that we do to address the social determinants of health.
Thank you. Sarah, if we want to go ahead with the first question.
Okay, great. I'll jump right in. Okay, so one of the first questions we got last week, crime is often a major challenge in disinvested neighborhoods, yet distrust between law enforcement and communities of color complicates crime prevention strategies. How have you addressed community safety issues in the targeted neighborhood, and has the Columbus Police Department played a strong role in this work?
Great, well, thank you. I'll let Sheldon kick us off here with Community Development for All People.
Great, thanks, Nick. So one of the ways that we've addressed that is really through relationships, and the Columbus Division of Police has played an important role with that. We have, the South Side isn't a neighborhood, it's more so an area that's an amalgamation of several different neighborhoods. So all those different neighborhoods have civic associations. So we have a variety of staff members that attend those monthly civic association meetings, and all those civic associations also have a community resource officer from the Columbus Division of Police. So building relationships on, kind of that neighborhood leadership level, and having the opportunity to know that we're partnering with the police and with the mayor's office and other parts of the city government has really been the way that we've tried to address public safety. And of course, getting rid of blight in the neighborhood is itself a way to address public safety. But in terms of the relationships between the police and the community members, that's one of the primary ways that we do it.
And just following up on that, the hospital, in partnership with Community Development for All People and other community-based organizations and community leaders, have been engaged in several special projects over the last few years that have aimed to directly impact crime in the surrounding neighborhood. However, we really feel that the holistic approach that HNHF takes with the five prongs really does indirectly affect the safety element of the initiative. So some of that is obviously rooted in the work that Gretchen's team leads with the housing and creating stable, affordable housing opportunities for families, but that also is with our emerging work in the employment side of HNHF and getting folks into livable wage career pathway opportunities where they have a chance to earn that living wage and provide for their families. That's also working with our local schools and providing mentoring opportunities for our kids in the community. And lastly, that's with our community relations folks helping the neighborhoods start up a block watch that is community-led, community-driven, and supported by the hospital to address any type of safety concerns, but also to build that relationship with the police department. That is an ongoing thing and conversation, but is one that is yielding some positive returns.
This is Kelly. I do think it's a critical issue, too. And from a metrics point of view, we have been able to report that there's a decrease in property crime in the area. But, we're not satisfied with that measurement, and we believe that, crimes against persons is more important. And we are working right now on data that accrues over a 10-year period, what the trends have been in crime, but we're not ready to report that and won't be for a couple more months. So I hope we'll have some answers on how it's working.
Thank you.
Okay, great. Thank you, guys. Next question we have is any screening being done in your catchment area for adverse childhood experiences and its health and educational impact?
Great question. So we have pilot work happening in a couple different domains related to that. So the direct answer is only in a couple of child care centers. So using Bruce Perry's model on regulating children and looking for early childhood trauma, we do have some assessment. But really what's happening more than that is many of the medical providers are beginning to screen for social determinants broadly, and that includes, access to housing insecurity, food insecurity, violence in the community or home, transportation problems. So we are rolling out a more comprehensive social determinant screening, but the adverse childhood experiences is really coming up mostly in our behavioral health outreach efforts on prevention through the Incredible Years and the Positive Parenting Program. Not as formal as we'd like, but beginning to roll out.
Great, thank you. And the next couple of questions we have are a little technical on the CD4AP homes that are being built, and I don't know if you want me to pull up any of those slides that you shared previously, but the next question is, were the homes CD4AP built with LIHTC, sold, or rented? If so, how did that work?
So the single-family homes, that was our first low-income housing tax credit property. So those were leased. It's actually a lease-to-own situation. So it's I think 10 years till 15 years, where the tenants will have the opportunity to be able to purchase. So we're only a few years into that. So none of them have been sold yet.
But Healthy Homes has been doing housing since 2008. We have a home ownership prong. We've sold over 90 homes through that model. We also have a rental program where we've done about 45 units in a home program.
Okay, great. And the next question is, in one of the previous slides, it had indicated that there was a plan to sell about 15% of the homes. So the question is, what will happen to the tenants that are living in those homes if they are sold?
So if we have to sell a portion of our portfolio in 10 years in order to refinance in the private market, then, we haven't spent a lot of time talking about it, but there's always a vacancy rate. So I assume that if we need to sell particular units, that those tenants will be incentivized to move to another unit that we own, or we have lots of community partners, including Community Development for All People and other housing nonprofits, that we would rehouse those families so that they still have affordable housing.
And this is Kelly again, and our experience is early on the rental side, but there is a transition routine process whereby some renters don't make it. They are unable to maintain rents, and would hopefully we rehouse them and work with them and try to find solutions. But sometimes they are evicted, And there are other, fortunately, our experience has been more that people move up if they get job training and other supports. So people don't stay in the neighborhood for a long time, or in this particular housing for a long time, because they often say their families are growing or they need to move for various reasons. So there are many, many reasons people move, and there's usually a 2 or 3 year. We haven't developed our own average rental time yet, but there are others in the neighborhood that have, and so we're using those kind of markers as people will roll. It's a 10-year period is for reselling is for a portion of the portfolio. We don't believe will be a problem.
Okay, great. Thank you. I've often heard from healthcare systems and MCOs that one of the challenges with investing in strategies to improve social determinants of health is that it's tricky to ensure that the strategy, for example, that with affordable housing, is reaching people who are in fact patients of the hospital or insurer. From your description, it sounds like the Healthy Neighborhoods, Healthy Families program reaches residents of the community regardless of whether they are nationwide patients. Is that correct? And if so, how are you able to make the business case to others in the hospital that it's worth investing in housing, workforce development, education, et cetera, even when the benefits of those services don't affect your patient population?
So there are political, moral, and financial implications of that question, and I'll just, I think I can do this quickly, but basically, yes, it is true that some children and families who are not patients of our institution or members of our accountable care organization do benefit from what we're doing. That's a lesser number than in some other places because of our market penetration and because our accountable care organization actually has subcontracts with all of the Medicaid managed care organizations. So we have worked very hard to make sure that when we do child-oriented, school-based or home-based or neighborhood-based incentives, we touch as many of the children on Medicaid as possible. There are some children that, again, we are providing services for people who we do not care for, but our belief is that by reducing costs of care in the long term, improving outcomes in the community, our long-term position, we've been in this neighborhood 150 years, and we hope to be here that much longer. So we will benefit our long-term financial viability by making sure we have a healthier population. We do see the problem that other managed care organizations, healthcare systems do when the markets are more fragmented. So in many places there are multiple pediatric providers or MCOs and they compete. But even in those cases, we see places like Portland, Oregon, or New York, other places where there are Medicaid waivers and other activities where people are being incentivized jointly to improve outcomes. So we think that this is the way people will work in the future in communities, that you will need to work on social determinants, that it will be, if not a market penetration like ours, it will be a shared responsibility to improve the lot of low-income communities or areas of concentrated disadvantage.
Great. And the last question that we have from last week, though, I'm happy to unmute everyone if the presenters are open to that to see if there's any additional questions. But the last question is, how can we begin to replicate this program in our state? Who initiated your program's relationship and buy-in?
So there are a lot of different people that were involved in the initiation, and it was actually a combination. I would welcome Sheldon and Gretchen both to weigh in on this from their respective places, but CD4AP in the community was initiating on a very small level some housing initiatives and efforts. At the same time, the mayor was looking for ways to change the massive foreclosure that had happened on the south side of Columbus, and what could we do with neighborhood support funds and other programs. The hospital was looking to improve the area around its campus, as well as to make a difference on where their employees and patients lived and worked. And our accountable care organization was looking to make, save money on one of the most expensive neighborhoods in its entire portfolio. All of those things came together, and allowed us to raise up the opportunity to do the right thing by children and families. And so we had a collaborative community where different players could each see the benefit to their organization and their participants and members, and people were able to come together. I do think it takes an incredible amount of trust across organizations. It takes a lot of patience. We're experiencing some positive effects right now, but it was 8 to 10 years of behind-the-scenes labor and partnerships and agreements where each player has played many different roles, from initiator to facilitator to financer to underwriter, even leveraging organizations like the United Way and seeing how they have been willing to change their funding patterns to leverage and extend the work that we're doing together where they see benefit. So, Gretchen, Sheldon, do you guys want to add to that?
This is Sheldon. I think one of the things I think is important, that Dr. Kelleher mentioned some of the broader lessons I think could be learned for any state, any community. But some of the specific things, of course, were just where things came together with specific, partners in Columbus and here on the South Side. But for anyone that's interested in replicating this type of work, I think it's important to think it's a typical story, right? A hospital, serving as an anchor in a low-income neighborhood, and I think having the opportunity to explore what are the local organizations that are doing work in your community, I think would be an important first step. I'm very proud of the work that we do at CD4AP. I think that we're a well-run organization, but it really took the investment of our partners at Nationwide Children's Hospital to allow us to scale the work that we were doing at a much larger level, to be able to maintain the level that we're at. And we've grown as an organization because of our partnership, because of that investment. And I think capacity building of local organizations is important, because none of the partners involved in Healthy Neighborhoods, Healthy Families could do this great work alone. So I think the first step in trying to replicate this would really be, or perhaps the second step, the first step is thinking about, making the decision to do so. But the second step would really be looking at the local landscape and figuring out who the potential partners are and where the opportunity for collaboration lies.
I like that, Sheldon, and I actually think that, the hospital, even with the best of intentions and lots of business reasons to be engaged, wasn't well connected with the neighborhood as it could have been. And so having a community quarterback like CD4AP and having the United Way to provide a leadership academy and training for our local people on how to be involved, the residents to engage them more effectively. So, hopefully we've gotten better at engaging residents ourselves over time. But I think speaking the two languages, having the hospital provide political and business savvy and resources, and having United Way and CD4AP connect with the neighborhood and truly engage people, that combination's been a powerful opportunity for us. And then politically, I do want to say, some people say, well, why would the hospital do this? We do have the Accountable Care Organization, but there's also different people in our organization who have a vested interest. So our president and COO is very interested in having, a nice campus, safe place for patients, a safe place for employees, ability to expand the campus and take on be more integrated into the community. Our, HR folks want our workforce to live in the neighborhood, be close to here, and to look like the neighborhood and be part of the neighborhood. So, they're committed to that. Our CFO is very interested in the partnerships with the Accountable Care Organization, with the community, and leveraging grants and resources from other partners like the mayor's office and tax abatements and other things that can happen, and new partners in business development. And, the CEO believes it's the right thing to do. So each person in the organization has a different perspective, but they all see the benefit from their perspective in doing this.
And this is Sheldon again, just to build one final thing off of that question. For those of you who were on the webinar last week, you had the opportunity to hear from CD4AP's founder and executive director, Reverend John Edgar. So I think kind of building off of what Dr. Kelleher was saying, as an organization, CD4AP really believes in asset-based community development. And I think everything Dr. Kelleher just said really, hammers that point home. I think that there's a moral reason to do this work because it's good for children and families. There is financial benefits to not just individuals, to the hospitals, but also to the city itself. It's not good for for the financial aspects of the city to have blight. That's not having houses and good reuse. It's not building a tax base. It's also not good to have the missing human capital of having high levels of unhealthy families, having high levels of unemployment or underemployment. So there's really a lot of opportunities and assets to be able to meet a lot of self-interest, not only doing the right thing, but doing the right thing in a good way that served a lot of things. So I think kind of to the previous question again, just thinking about where are the opportunities to kind of address not just, issues and problems, but what are some assets that can be built upon to really serve, all the potential collaborators in doing this type of work.
Hi, Nick and everyone. It's Jenny. I have a question following up on your comments of capacity building. Can you maybe get into a little more detail of what type of capacity building you provided for the organizations in the neighborhood and the folks? And I guess secondly, how did you measure if you were moving the needle?
Our goal, that's a great question. I think the measurement thing is, the measurement area and how we do that is a huge issue. And the funniest thing about it is every part of the hospital measures the outcomes differently. Every part of the neighborhood measures the outcomes differently. We do have a target dashboard, and that is how we're affecting infant mortality, kindergarten readiness, and high school graduation. Those are our North Stars. Those are long-term change things, though, and so up till now, we've been measuring. We have a dashboard, and we measure, some outcomes in each domain. For the housing, we've measured the number of, affordable housing units that we are adding to the community, and how that's hopefully changing some of the other things like. Up till now, property crime, and we're starting to measure personal crime. We are also following high school graduation in the area, and we're starting to follow how much churn there is in schools and movements for the number of kids there. We do know we have indicators of the utilization of the emergency room and hospitalization by Medicaid kids from these neighborhoods, and they have gone down compared to other neighborhoods that are nearby, but we are trying to, compare to more neighborhoods, so it's just not two neighborhoods alone. We also survey rough 250 households a year on how they feel about living in the neighborhood, how much of a neighborhood it is, whether they feel safe, whether they feel proud of living there, whether they feel like they're part of the neighborhood. And those indicators are steadily rising each year. So, and lastly, we're tracking the number of children on Medicaid in each census tract to make sure we're not displacing people. And so far, that has not happened.
A couple of other points there around kind of how is it done. Sheldon mentioned community development for all people's asset-based approach, and I think that with a lot of the, especially non-housing efforts that we've entered into, we've really looked at taking that approach and building up our partnerships and rolling out our programs. So we're not or create something new, but really build upon what really brings people to the table and engages them, and then build the capacity of that program off of that. So that's really central to our Fannie Mae funding that we received recently. Community Development for All People sees 20,000 people a year. Gretchen's team is rolling out 170 new rental units to the south side, and so being able to connect folks with workforce training, the audience is built in right there, so we're building off of that asset. The other piece comes around sustainability and funding, and Kelly mentioned our CFO being really instrumental in the partnerships and how everything is financed, especially on the housing side. We've really taken that approach in our other partnerships and efforts, and that one organization is not, for lack of a better way to put it, on the hook for the total investment in any program, that it is an equal investment and partner share in the financial side of it that has a long-term diversified funding plan to it, so that we have that time to really measure and evaluate success, and that, you know, it's not a one-year type of thing with one funder, and if we don't see results of some intervention that's addressing a problem that's taken tens of years to create. And so the diversification in our funding and how we leverage our hospital investments with external funding is critical to capacity building and sustainability of our efforts.
Thank you.
Great, thanks so much, guys. If it's okay, I'll go ahead and unmute everyone now, so if anybody has any questions that they want to ask, you'll be unmuted, and just a reminder to please mute yourselves on your end if you don't have a question. So everyone is unmuted now if you have any questions. All right, well, I think that might be the end of the questions, but thank you guys again so much for agreeing to do this follow-up and Q&A. We'll post a recording of this webinar along with the original webinar on our website so people can view it there, and we'll also send a follow-up with the recording after this webinar is over. So thanks everyone for joining. We really appreciate it, and thanks Nick and team for participating again. Thanks.